Hello, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are Oncology Brothers. Today, we're thrilled to have a nationally known researcher and a clinician, Dr. Neeraj Agarwal from Huntsman Cancer Institute, to walk us through the current standard of care for prostate cancer. Dr. Agarwal, welcome.
Thank you very much for the invitation. It's such a pleasure to be here.
Dr. Agarwal, in this algorithm, we hope to keep our focus on recurrent and advanced prostate cancer, as this is what we tend to see in most of our patients. Can you please walk us through this algorithm, starting with castration-sensitive prostate cancer part?
Of course, most of the patients develop metastatic castration-sensitive prostate cancer from a prior history of a localized prostate cancer, which is called metachronous metastatic castration-sensitive prostate cancer. Only a minority of patients develop what we call as de novo or synchronous metastatic CSPC or castration-sensitive prostate cancer. So let's talk about the metachronous disease first. But radiation and surgery is curable in many of these patients, and they develop a state known as biochemical recurrence because they start to notice PSA going up after this curative intent treatments. Right now, there is no standard of care for that state of cancer. We can argue on PSMA PET being done and showing metastatic disease somewhere, which you can target with oligometastatic approach. We can talk about intermittent versus continuous hormonal therapy. But bottom line is, that is the state where there's no standard of care right now. And then finally, we see a state of metastatic castration-sensitive prostate cancer.
Dr. Agarwal, you briefly mentioned the use of intermittent ADT. That is something that comes up frequently in community practice. Where do you see using intermittent ADT and for how long? What would be the right patient you would consider that for?
This is one of the most challenging questions, in my view, in the entire prostate cancer spectrum, especially after the advent of PSMA PET scans. You start ADT with mostly GnRH agonist when the PSA is 10 or 20, and then stop ADT when PSA drops to 4 nanogram per mil or less. Nowadays, if somebody has biochemically recurrent disease, I always order a PSMA PET scan. Berylify or gallium, doesn't matter to me. Whichever is available, I get the scans done. If scans show no evidence of metastatic disease, the decision-making is pretty simple. We have to talk about the patient is now diagnosed to have biochemically recurrent disease and has to be offered some kind of ADT or just delay all ADT and metastatic disease. So that is another level of discussion. The second is, if the patient is found to have PSMA PET positive disease distantly, but conventional scans are negative, my practice is to again treat these patients like they have biochemically recurrent disease. The third scenario is when patients have localized prostate cancer, such as a lymph node or something really in the pelvis. Those patients should be treated with definitive intent salvage radiation therapy or salvage surgery. Why do we use intermittent therapy in biochemically recurrent setting? Because my patients want to have a break from castration so that they can have normal physical, mental, romantic lives with their spouse. They can get a chance to get their muscles back, bones back. They can allow their cardiovascular systems to recover. And I often see that when I use GnRH agonist, the testosterone doesn't recover for months to years in these elderly men. Older we are, more likely we are not going to recover our testosterone after GnRH agonist injection. So I'm increasingly using relugolix, which is a GnRH antagonist, to treat these patients. And the best part about GnRH antagonist is that we see recovery of testosterone within weeks. So yes, they will again have PSA coming back after this initial temporary phase of castration, but then the break they get is the real break.
Thanks for going over that, Dr. Agarwal. Now, advancing to M1 disease. How do you select someone receiving dual versus triplet therapy, especially after the recent approvals? And when selecting docetaxel, how many cycles do you, in fact, consider?
So second question is easier. If I'm using docetaxel chemotherapy in metastatic castration-sensitive prostate cancer, I use 6 cycles of docetaxel maximum. Many patients may not want to continue up to 6 cycles. We do see occasionally patients stopping after 4 cycles because of complications, neutropenia, and so on. But 6 cycles is the maximum number of cycles I use, which is based on level 1 evidence from the Charter trial. Coming back to the first question, where I use doublet and where I use triplet. Using triplet of docetaxel plus ADT plus a novel hormonal therapy with either darolutamide or abiraterone is easier in those patients where I was going to use ADT plus docetaxel, because these triplet therapies have so far shown that triplet therapy is better than ADT plus docetaxel chemotherapy. We have never had a single trial so far showing that triplet therapy is better than ADT plus a novel hormonal therapy, such as enzalutamide or abiraterone or apalutamide.
Absolutely.
So the question here is, I used triplet when I was going to use docetaxel chemotherapy. So there's no role of ADT plus docetaxel anymore. So now let's come to the discussion of who should get docetaxel and who should get novel hormonal therapy, because ADT plus docetaxel has no level 1 evidence anymore. So if I look at the results of the Titan trial, Arches trial, Enzamet trial, Latitude, Stampede, all these trials which have used ADT plus different types of oral novel hormonal therapy, almost all those trials have shown benefit in high volume disease, low volume disease, high risk disease in the case of Latitude, low risk disease as we saw in a Stampede, older patients, younger patients, regardless of whether they received chemotherapy in the past, except one subset of patients. That is patients who had liver metastasis or visceral metastasis.
Mhm.
And these are a very small number of patients. Maybe 7% patients with metastatic castration-sensitive prostate cancer have liver metastasis. So my preference is to go with ADT plus one of the hormonal therapies, either apalutamide, abiraterone, enzalutamide, whichever patient can tolerate, and only consider triplet therapy when I see visceral metastasis or at least 2 of the following 3 mutations, P53, P10, and RB loss. If I see all 3, straightforward decision. They have to get chemotherapy. But if I see 2 of the 3, I also tend to offer chemotherapy in chemo-eligible patients.
Those are some excellent points. Thank you for going through that. I think we can now dive into the castration-resistant prostate cancer. Dr. Agarwal, can you walk us through this part of the algorithm as we continue to see more and more drug approvals in this side?
If you look at castration-resistant disease setting, we are really seeing a revolution in terms of novel drugs with novel mechanism of action. So yes, we saw the approval by FDA for pembrolizumab in MSI-high prostate cancer patients, but then we also saw the data on cabazitaxel, the CAR trial. Cabazitaxel used after docetaxel when compared to novel hormonal therapy was clearly superior in terms of progression-free survival and overall survival. So this was a new data regarding cabazitaxel, which was clearly distinct from the earlier data. I think CAR trial was the first trial which clearly showed that we have a viable option after docetaxel chemotherapy. And then PSMA-targeted therapies. Number 1 is the Vision. Vision is just a start. We are going to see other PSMA molecules coming soon. So the Pluvicto is superior to the control in patients who have received chemotherapy and novel hormonal therapy. In fact, around about half of the patients in the Vision trial had received cabazitaxel also. 44% patients had received cabazitaxel. So in these heavily treated patients, we saw progression-free survival and overall survival benefit with a drug with a novel mechanism of action. I think that's historic. And then we saw PARP inhibitors getting approved. We saw olaparib and rucaparib getting approved. And we saw the GeoASCO abstract titles being released. And we saw several more PARP inhibitor trials being presented. The older, like Propel trial, which was presented last year, will be updating the data regarding survival. So I think this is just a start in castrate-resistant prostate cancer. So this is fascinating. That's what I can tell.
Wow, truly is. It is only exciting right now, and as you stated, it's only going to get better. Looking forward to it. Diving into this a little bit more, Dr. Agarwal, if the patient presents who has received androgen receptor inhibitor previously, let's say for castration-sensitive state, is there any utility in switching the androgen receptor inhibitor agent here at the time of progression? Or would you rely on chemotherapy?
Great question. 75% of the practitioners in America or patients in the United States are being treated with novel hormonal therapy followed by another novel hormone. And this is based on Flatiron database. I often hear criticism regarding that approach. And I would say in many patients, this may be the right approach. And I'll give you an example. Let's look at the label of chemotherapy. Docetaxel chemotherapy has more side effects than oral hormonal therapy. There's no doubt about this, especially in elderly patients. And docetaxel label says symptomatic metastatic castrate-resistant prostate cancer, as long as you are talking about castration-resistant setting. Symptom or impending symptoms. So think about a patient in my clinic a few weeks ago who has disease progression on abiraterone after 3 years of being on abiraterone. PSA has risen from 1 point to 3 points, 3 nanogram per mil in last 6 months. Patient is not comfortable continuing abiraterone because PSA is rising slowly. We do not do scans every 3 months in real-world patients. We do maybe once a year to make sure you are not missing PSA non-secretory disease. But the real-world practice is I do scans, obtain scans maybe once a year, and I do PSA level a lot more often. So in this case, patient is otherwise completely asymptomatic, skiing on a regular basis, has PSA which is rising slowly. Tell me one evidence in favor of docetaxel chemotherapy.
Yeah, no, absolutely.
Right. So I use enzalutamide in this patient. I cannot justify using chemotherapy with docetaxel. If this patient, and by the way, we do see temporary responses to enzalutamide. There's nothing to lose here. We use alternate NHT. We see response, fantastic. You don't see response, you stop it. There's nothing to lose. There's not much to lose by giving chemotherapy to an asymptomatic patient who has no symptoms, low volume disease, and who's simply progressing by 2 or 3 points of PSA.
But yeah, and this is a common problem that we see in our clinics that we battle with. So thank you for addressing that. Dr. Agarwal, you briefly brought up some mutations TP53. Then we also brought up the use of PARP inhibitors in this castration-resistant side of things. In your practice, who gets tested for germline mutation and NGS?
Everyone. When I see the patients for the first time, I order CBC, CMP, PSA, and many other tests like testosterone levels, CT scan, bone scan. In a typical patient with metastatic hormone-sensitive prostate cancer. And in the same clinic, I order germline testing or genetic counseling through a genetic counselor's clinic and tumor NGS profiling. If tissue is not available, we order liquid. Sometimes we order both. But tumor NGS has to be done in one way or another. So first of all, if I look at the PROFOUND trial, where I was involved with in the steering committee of the trial, one of the most striking aspect of the trial was that 30 to 35% patients could not even be screened for that trial because they did not have tissue available or tissue did not have good quality. So by the time you let patient progress to CRPC, there is a good chance that 35% chance looking at the PROFOUND data that either we lose the tissue or lose the tissue from the perspective of quantity or quality. So that's why I get it done. I know what is the mutational status. So when the disease is progressing, especially clinical disease progression, I don't want to waste time in trying to get the mutational profile done. Then I'm ready with my choices at that point of time. But another important aspect is that tells me the NGS profile of the tumor tells me how often I have to follow my patient in the clinic, or what is the prognosis. If I see somebody to have, say, P53, P10, and RB loss mutations, I know if I see triplet mutations, I know patient is going to require scans every 3 months. Patients are likely going to have non-circulatory progression, so they may not progress by PSA. They are more likely going to progress by scans. So I'm going to do scans every 3 months, and I'm going to see them probably every 6 weeks. If I do not see any of those mutations, and in fact, if I see SPOP mutation, which we reported last year in ESMO, that SPOP mutation predicted very good outcomes with novel hormonal therapy, I'm more relaxed. I think I can allow a patient to not come back to my clinic for next 3 months. So I think using the NGS testing upfront allows me to assess the prognosis, assess how to follow up my patients, and to be ready with a biomarker-targeted therapy or a clinical trial when they're having disease progression.
Thank you. That, and just very recently with the P10 mutation, the data was presented for San Antonio breast cancer with capivasertib, which looks very exciting. So this is all very helpful. While we're at the topic of all these mutations, we've talked about PROPEL being presented at last ASCO. In your clinical practice outside a clinical trial, who do you think you'll be using the combination PARP inhibitor for?
First of all, we don't have any of those approved in the clinic yet. So I have to wait for the FDA.
Yes.
Once they're approved, and looking at the magnitude of survival, like how much time we got, what was the delay in disease progression? And number one reason being, many of these patients, again, from the Flatiron databases, we see attrition of half of the patients from first line to second line. Only 25% patients receive third line therapy,
wow,
and only 10% to 12% patients receive fourth line therapy. So if I get a chance to use a drug upfront, I would like to utilize that. As long as patients are eligible, patients don't have contraindications, and so on.
Coming back to our approved line here, if patients have progressed, now you have option of cabazitaxel or Pluvicto. How do you make that decision, and what do you go for?
Great question. I was expecting that. So if you look at therapy trial, that's one of the trials which was randomized 200 patient trial where lutetium or Pluvicto was compared with cabazitaxel, head-to-head fashion. I would like to bring your attention to the eligibility criteria. These patients had to have at least one lesion which has a SUV uptake of 20. And they could not have any lesion which was measurable and had a SUV of less than 10. So these are like really high expressing, PSMA high expressors. These patients were randomized to cabazitaxel versus lutetium therapy or Pluvicto therapy. Without getting into the nuances of hazard ratio, progression-free survival and PSA response rates favored Pluvicto. But if you look at overall survival, it was similar in both arms. even though progression-free survival and PSA responses are better with Pluvicto. So what I get from this? My message from this trial, both are valid options. If patients are progressing on docetaxel chemotherapy, I tend to offer them Pluvicto first because it has other attributes such as delaying PFS better or delaying progression better and delaying PSA progression. And I think side effect profile is different from docetaxel, so there's a nice change in the side effect profile. However, if I'm not able to find Pluvicto because of the ongoing shortage, I do not hesitate offering them cabazitaxel.
To recap, with all the available agents in metastatic disease, there is limited role for docetaxel alone. PARP inhibitors will give us more treatment options for our patients, and cabazitaxel, along with lutetium, continue to be good treatment options for heavily treated population. Dr. Agarwal, thank you so much for taking the time to share your thoughts with us today and reiterating the standard of care.